Okay, let's talk about anaphylaxis. This is one of the most critical medical emergencies you'll ever face, where every single second counts. Getting this right, and getting it right fast, can literally be the difference between life and death. So we're going to walk through a super high-yield guide to make sure you're ready for your exams, and more importantly, ready for that moment in the clinic.
Now, before we dive in, a huge shout out and credit where it's due. This entire guide is built on the fantastic educational work of Dr. Mohammed El-Nagagi Mohammed. We're just bringing that crucial knowledge into this format to help it really stick with you.
So here's our game plan. We're going to follow the patient's journey from the moment they come through the door. We'll start with spotting the reaction, then jump straight into the immediate actions and the all-important dosing. After that, we'll tackle the scary stuff, what to do when it's not responding, and finish up with the essential care after they're stable and how to discharge them safely. All right, first things first, recognition. You can't treat what you don't see, and with anaphylaxis, you've got to see it fast. So when the pressure is on, what are the absolute key things you need to be looking for? Okay, let's get the textbook definition out of the way. The words you need to lock onto here are severe, life-threatening, and systemic. This isn't just a minor rash, right? This is a full-body, runaway train of a reaction that can turn fatal in minutes.
So what's the likely culprit? Well, the patient's age is a massive clue. If you have a child in front of you, your brain should be screaming food allergy. Think nuts, shellfish, that sort of thing. But in an adult, you're much more likely looking at a drug reaction or maybe an insect sting. A couple of quick questions can often solve the mystery right away.
You know, the Rhesus Council UK really boils this down for us, and honestly, it's brilliant. It all comes down to two things. Number one, speed. This thing comes on suddenly and gets worse fast. And number two, this is the absolute clincher. You've got life-threatening problems with the ABCs: airway, breathing, or circulation.
So what are we actually looking for? Let's run through those ABCs. For airway, you're listening. Is their voice suddenly hoarse? Can you hear stridor, that awful high-pitched noise? For breathing, you're looking and listening again. Are they wheezing? Are they obviously struggling for breath? And for circulation, check their vitals. Is their blood pressure dropping? Is their heart racing? If you have any one of these, you have anaphylaxis.
Okay, you've made the call. Your brain is flashing anaphylaxis in big red letters. Now what? What is the single most critical thing you do in this exact moment?
I really want this to sink in. This is one of those incredibly rare moments in medicine where you just don't have time to second guess or look something up. You can't pause, you can't hesitate. You have to act from memory, and you have to act now.
And here it is, the single most important takeaway of this whole talk: intramuscular adrenaline. That's it. It is the lifesaver, and you have to give it immediately. Everything else, literally everything else, can wait. Get that adrenaline in first. Okay, so we know what to give, but knowing how much and where, well, that's absolutely non-negotiable. This is bread and butter stuff for your exams and, more importantly, for keeping your patients safe in the real world.
All right, this table, you gotta burn this into your brain. Seriously. But here's an easy way to remember it. For adults and anyone over 12, it's 500 micrograms. That's half a mil. For school-age kids from 6 to 12, it's 300 mics. And for the little ones, 6 months to 6 years, it's 150. Just think, 500, 300, 150. Got it?
All right, you've got the dose drawn up. Where are you putting it? Straight into the anterolateral thigh, middle third. Simple as that. And what if they're not turning a corner? You hit them again in 5 minutes. No hesitation. Every 5 minutes until they get better.
But what if that doesn't work? You've given 2 appropriate doses, you're watching the clock, and things are still going downhill. They're breathing, their circulation, it's just not getting better. Now what do you do?
This is where we get into what's called refractory anaphylaxis. This is that nightmare scenario where your first line, most powerful treatment just isn't cutting it, and you need to escalate fast.
So what exactly is refractory anaphylaxis? The official line is this: their breathing or circulation is still tanking even after 2 good doses of IM adrenaline. The moment you recognize this state, it is your trigger to escalate your care immediately.
So what does that escalation look like? 3 things. 1. Get a line in and flood them with IV fluids for that shock. 2. Scream for help. Seriously, get your senior, call ICU, get an anesthesiast. You need backup now. And 3. You start thinking about an IV adrenaline infusion, but, and this is a big but, that is only done with expert help on board in a monitored setting.
Okay, deep breath. You've pulled them back from the brink. The patient is stable. Awesome work. But we're not done yet. Not by a long shot. Now we shift gears to the essential post-stabilization care to make sure they stay safe.
So here's your post-crisis checklist. You'll give some non-sedating antihistamines for the skin stuff, the itching and hives. You might want to send off a serum tryptase level, which can help confirm the diagnosis later. And here's the really crucial part for their future safety. Every one of these patients needs a referral to an allergy clinic, and they absolutely cannot leave the hospital without 2 adrenaline autoinjectors and proof they know how to use them.
Now, you might be thinking, they're fine now, why all the fuss? Well, it comes down to this number, 20%. 1 in 5 patients. That's how many can have a biphasic reaction. What's that? It's when the symptoms roar back to life hours later with no new trigger. It's a hidden danger waiting to happen, and we have to be ready for it.
And that risk of a second wave is exactly why we have to be smart about discharge. This leads us to our last really important topic. When is it actually safe to send someone home? And trust me, it's not a one-size-fits-all kind of deal.
Thankfully, the Resus Council UK gives us a really practical, risk-based playbook for this. If it was a simple case, 1 dose of adrenaline did the trick and they're back to normal, a couple hours of observation is probably fine. But if they needed 2 doses, or they've had a biphasic reaction before, you're going to watch them for at least 6 hours. And for your really sick patients, the ones who needed more than 2 doses, have bad asthma, or live out in the middle of nowhere, they're staying with you for a good 12 hours.
And that really brings us full circle. You've done everything by the book, your patient is stable, they've been observed, they're ready to walk out the door. But here's the last question we have to ask ourselves. Are they actually prepared for what happens outside the hospital? Because making sure they have the tools and the training for the next time, that is just as much of a life-saving intervention as anything we did for them today.